guests in. Welcome everyone to the 306th gathering of the Right Care Initiative, which was started in California about 15 years ago. We have twice monthly University of Best Practices virtually by Zoom. We used to gather in person, and we're so grateful that now that we gather virtually, we have guests from other parts of the country, many more counties across the state, and even other countries. So today I want to particularly thank the Environmental Protection Agency for sponsoring this particular meeting and research in this area about the health effects of wildfire smoke, and particularly with regard to asthma and cardiovascular disease. The contents of this meeting will be posted on our website, rightcare.berkeley.edu, within 48 hours. We will have continuing medical education today, and that link will be sent to you by chat. If you have operations questions, please direct them to albert1030@berkeley.edu, and please don't chat them out to the group generally. Operations questions should go only to our operations team. And let me introduce them to you. That's Albert Yeam. You see his, he's with us here today, along with Jenny Wu. So for any continuing medical education questions, please direct them to Alyssa Meyer and that will also be chatted out to you. So we are particularly grateful for, as I said, the Environmental Protection Agency, as well as the California Department of Public Health, the Los Angeles Department of Public Health, Blue Shield of California, our University of California mothership, Berkeley, University of California, San Francisco, the California chapter of the American College of Cardiology, the Stroke Awareness Foundation, and our biopharmaceutical partners. Next slide, please. So most of you know me. I've been working on clinical quality improvement my entire adult life, going back to college at UC Davis and then on to a public policy school at Harvard, and then working for the state of California and the School of Public Health at Berkeley. Next slide, please. This slide synthesizes what we try to do in the Right Care Initiative, and that is we want to activate the patients and we want to activate the physicians. And I think we should probably update this slide to talk about patient and clinical team activation, because a lot of what we can do that improves patient outcomes is activate the patient team to learn to be proactive with reaching out to patients on implementing what we know to work. So we work based on what is evidence-based, the best available evidence, and we work with many partners across the state. Next slide, please. Our chairman is Dr. William J. Balmer. He is not only the longtime chairman of the Right Care University Best Practices and a specialty delegate to the California chapter of the American College of Cardiology and the California Medical Association, he also directs the state of California's PCI, Clinical Quality Improvement Program. He's trained many cardiologists over the years in his work as professor of medicine at UC Davis. And he most recently has adopted the title of chairman of the California Department of Public Health's Master Plan Steering Committee. So we'll be working together on that over the next year. He has more awards than we have time to talk about today, more papers, more innovations. So with that, I'll just say that he's an honorary lifetime member of the British Cardiovascular Society, And he is our exemplar for exercises medicine with skiing and marathon running, not to mention boating across Lake Tahoe, etc. So with that, let's turn it over to our dear chairman, Dr. William J. Balmer, and welcome to our leadership and guests across the nation. Next slide, please.
So thank you very much for that introduction, and I am going to go on to share content. And can you see my first slide?
Bill, I thought you were going to be, we were just in the master deck looking at the agenda together. But
Jenny, can you, I put share content. Do you have my slide up now?
We do not see your slides.
Okay, we'll do it again then.
So sometimes our speakers get very motivated over the weekend, and we have to adapt to surprises. So we can now see you are sharing screen, but we cannot see any slides, Bill.
And I just lost power at my house, so I'm on my phone. So
wow. Okay, well, we will be forwarding your slides, and it may be that Bill might have to present them for you, Dr. Ivey. Okay, so we see a tree. Great.
Got it. Okay, so I certainly want to welcome everyone today to this program for Right Care. It's especially topical for us in California. As you know, California has perhaps more wildfires and loss than any other state in the country. And we're talking about the fact that wildfires in California have killed individuals. So this is literally a lethal disease. It has killed healthcare providers. It has closed hospitals in California that have been lost in wildfires. And it is certainly led to significant problems throughout the state that we have each year, including last year where we had serious smoke inhalation problems with literally air quality numbers that were in the 400 and 500s, which were clearly unsafe. So this is topical. It is important that every one of us practice wildfire adaptive responses, including around our residents, including industry for that as well. It is important that we remember the original message of Smokey Bear that only you can prevent wildfires. And this is important to every one of us on the conference today that we can be part of it. The Berkeley mascot shown in the upper right is also responsible. Remember, we had serious fires in Berkeley that in fact it led to significant damage at that area. So the topic today that Dr. Ivey will be presenting and leading is certainly topical, needed vitally by all of us in California. Very important that we go on with that. So Dr. Ivey, as we all know, is a longtime member of Right Care Initiative. She, in fact, is a duly boarded emergency and family practice physician working in the ER for over 30 years in California, and has degrees in public health and is on the faculty of public health for UC Berkeley. And important for today is the co-PI of this EPA-funded wildfire smoke project, which she will in fact talk about today as we explain. So we're delighted to have the expert in wildfire smoke, Dr. Susan Ivey, present and introduce our two speakers that are shown on the left today. So Dr. Ivey, let us know if your computer is working and you're on internet, and you can take it from here.
I see that Dr. Ivey is muted. So I will just wait until—
Can you guys hear me?
Yes, we got
Yes.
you.
Okay, great. I'm on a phone. Sorry for that. So I missed that part because of a power outage. Wonderful California stuff. But I just wanted to do a little bit to orient everybody to the grant itself, talking about communicating risk of wildfire smoke. In this situation, we're communicating those risks for our right care provider, hard to reach populations. Next slide. This is a funded project of the Environmental Protection Agency, and one deliverable of the award is a continuing medical education program on the health effects of wildfire smoke. So this is it. I'm not trying to say that providers are necessarily hard to reach, but we're glad to be able to reach the right care audience today. None of our speakers have any commercial disclosures to make. Two of the speakers, myself as co-PI and Dr. Holm as a co-investigator, are funded under the EPA STAR grant. Next slide. This one introduces a little bit to, are you advancing? Yeah, to
Yes,
the
got the research
team.
team up.
Dr. Linda Newhouser might be in our audience there. She's the lead PI with myself and Dr. Jason Su from Environmental Health Sciences at Berkeley, and Dr. Stephanie Holm. Yep, Dr. Stephanie Holm as a co-investigator, along with other co-investigators in our communication unit, Mr. Anthony Eleftherian, and our project manager, Morgan, and Hattie, of course. Just briefly, next slide, the project objectives will be creating a new, more precise model of California wildfire smoke risk data. Albert, are you advancing?
Yes.
And we'll be
Yes, he is.
conducting a needs assessment of the wildfire smoke risk communication, including a literature review and environmental scan for any existing materials about reducing risk of wildfire smoke. Today's presentation there in red is a continuing education course for California's healthcare providers. And we have other deliverables that will follow in the next year. Next slide. Albert, can you advance to the next?
Yes, I advanced.
Yes, he did.
Or Jenny?
Dr. Ivey's just
either?
having a few technical difficulties because the power went out.
We'll be doing some silt exposure modeling to look at vulnerable communities in California, looking at PM 2.5 emissions and the intensity of emissions from California wildfires. Next slide. There's quite a delay.
Hey, Susan, this is John. If you turn off your camera, we probably have better audio.
Yeah, we have a very garbled audio from you.
I can jump in for a minute and just.
So Dr. Ivey, your audio is very problematic right now. Stephanie has offered to talk through these slides. And I
Next
think-
slide.
Yeah, I think let's do that. Stephanie, if you could just take over, because we've just lost almost all audio from Susan.
Sure, absolutely.
Go
Can you
ahead.
hear me now?
Yes.
You
Very-
guys hear me now? Okay. Thanks,
I
Stephanie.
think we'll have Stephanie do it because it's just intermittent with Susan right now. So Stephanie, take over.
Sure. So
Thank you.
one of the things, no problem, Susan. One of the things that we're doing in the project is identifying disadvantaged communities, doing that using CalEnviroscreen 4.0 data. CalEnviroscreen, if you're not familiar, is a project of the Office of Environmental Health Hazard Assessment within California EPA. And using that to identify census tracts in the top quartile of disadvantage from an environmental exposure and demographic standpoint. We're focusing on 6 counties, that's Alameda, Sacramento, Butte, Los Angeles, Fresno, and Santa Barbara counties, and generating some visual maps of those and of exposures using GIS, Geographic Information Systems slide. So this is an image demonstrating some of the California counties that have CalEnviroscreen 4.0 scores that are elevated for cardiovascular disease. These are counties with the top quartile of scores. And then these insets show our various counties of interest for the exposure mapping. So the sort of middle row at the top is Alameda County, below that Sacramento County and Butte County, and then on the right you see Los Angeles County, Fresno County, and Santa Barbara County. So you can see that within all of those counties, well, I guess maybe not Santa Barbara, but nearly all of the counties of interest have at least some census tracts within the top quartile for cardiovascular disease risk, which obviously is really relevant for this audience. Slide. And then this one shows census tracts that have a CalEnviroscreen 4.0 score for asthma that's in the top quartile. Again, showing statewide on the far left, and then our counties of interest in the same order on the right. And demonstrating that each of, or nearly each of these counties have some areas at the highest risk for asthma as well. Slide. And again, same kind of map. This time we're showing the CalEnviroscreen 4.0 overall score. That's a score that takes into account a combination of both the exposures as well as demographic factors that put these counties at particularly high risk of problematic health outcomes. And I see Susan back with us. Her power seems to be back. So Susan, I will let you take over on the next slide.
On battery here, but so as Stephanie said, the CalEnviroscreen gives us a really rich look at different places where there's vulnerabilities at the county level. Next slide. We also did an environmental scan. Our communications unit did a scan of available wildfire smoke risk communication materials to look at readability for low literacy, low health literacy audiences, for suitability and whether they followed clear communication principles. There are some tools that they use for this, suitability assessment of materials and PMAT tools, but they were able to assess videos, websites, and brochures. They identified about 81 public-facing materials about wildfire smoke exposure and assessed 19 information sheets, website pages, videos, and an app. 5 of the materials registered in the top tier of grading, but no one material could be considered a model of health literacy best practices. Next slide. Also, we've done a literature review that's complementary to the environmental scan. We identified gaps in peer-reviewed literature that evaluated wildfire smoke materials or programs. There are very few of those out of 456 articles. 33 were articles that we felt were acceptable for abstracting, and of those, only 19 articles could be included. Most of those were from the US and Australia, no surprise, with a few other countries represented. In terms of brief findings, just that we looked at what they recommended, that they said to use clear, concise, action-oriented messaging to disseminate wildfire smoke messages via multiple sources, including official announcements, news, social media, physical locations, and word of mouth, and to build better understanding among the public regarding the dangers of wildfire smoke exposure and how to reduce their exposure. So Dr. Holm will talk a little bit more about that as we go along. Next slide. We'll also be designing materials, as I said, using community engagement and participatory design principles starting in the fall, and then this continuing education course for providers. Next slide. So thank you for attending. Sorry for my technical glitches. I want to introduce my colleague and friend, John Balmes, who will take the next part of the program. So I'm going to just make this a little bit bigger. And John is one of Susan Ivey's many, many bosses over the years. So he was my director at the Joint Medical Program, which is where I teach and he used to teach. Also a pulmonologist and critical care specialist and professor emeritus of environmental health at UCSF, a professor and a clinician often in the past at San Francisco General Hospital in the divisions of occupational and environmental medicine and pulmonary and critical care medicine. He's also has been for quite a while a physician member of the California Air Resources Board. And I was fortunate enough to be able to work with him on a grant to be able to look more deeply at air pollution and cardiovascular diseases and other cardiometabolic. So I knew he would be an expert for this presentation and really excited to have him present to us. He's an internist by training from Mount Sinai, but also a pulmonologist, an occupational medicine specialist, a critical care person, and has been on faculties at USC, UCSF, and UC Berkeley. He also directed the UCSF Human Exposure Lab from 1990 to 2015, and has been studying respiratory, but also cardiovascular health effects of air pollutants for 40 years. Also, I reminded him on our check-in call that I remembered a distant article on diabetes or hemoglobin A1C. So he's going to weave in as much on chronic disease, related to outdoor air exposure as possible. So John, thanks for presenting to us and take it away.
Thank you, Susan. And to add to the technical difficulties today, there's construction going on outside my house and they're currently jackhammering. Can you hear it?
Yes.
I cannot hear it. You sound great, John.
All right. So I'm going to talk about outdoor air pollution in general and pivot to wildfire smoke and health in adults. And then my longtime friend and colleague, Stephanie Holm, will follow up with regarding wildfire smoke and children's health. So in terms of air pollution in general, what really put air pollution and health on the map were episodes in the 20th century in Donora, Pennsylvania, a steel town, or at least then, Meuse Valley in Belgium, which was steel and coal area, and then the famous London fogs. And this is actually a daytime picture in December 1951 during one of the famous London fogs. And you can see it was so dark that a police officer had to have a torch to guide where the bus should go. And this is a time series display of deaths in the hundreds in that December of 1951 in relation to exposure to British smoke, which is really black carbon, and then sulfur dioxide because it was sulfur containing coal that everybody was using to heat their homes. So that got people excited about the public health impacts of air pollution. This is a more current slide from a Lancet Commission on Pollution and Health from a couple of years ago that shows that air pollution was actually the single most important cause of premature death and morbid disease across the world, even more than tobacco smoking. It's in part because everybody in polluted areas, women, children, men, are exposed to air pollution, where tobacco smoking is often confined to adult men in developing countries. So there are really two types of sources of air pollution. There are so-called natural sources, and I say so-called because you can see wildfire here, and I would argue that some wildfires, especially here in California, are partially man-made, and we can talk about that. But then there's also volcanoes, which have been in the news not that long ago because there was a big one in the Canary Islands in Spain and another one in the Philippines not that long ago, and also Iceland. And then there's man-made sources, which usually get divided up into stationary sources like power plants and refineries and cement facilities versus mobile sources. Here I'm showing a motor, a passenger car, but it could be trucks, buses, trains, and planes and ships. Now, this complicated slide really has a simple message. This is a US EPA slide. And the only thing I want you to take away from this is that there's two types of air pollutants. There are those that come out of smokestacks and motor vehicle tailpipes. Those are primary pollutants, primary emissions. And out of tailpipes, for example, oxides of nitrogen are an important tailpipe emission from cars and trucks and buses. But then there are pollutants that get formed in the atmosphere, and ozone is the most important one in that regard. That's a so-called secondary pollutant. So the strategies to control these pollutants, primary versus secondary, sort of change depending on which type. And because I'm an environmental health sciences professor at emeritus at the School of Public Health at Berkeley, I have to talk about this environmental health pathway. And if you take wood burning, and it could be in somebody's fireplace, it doesn't have to be a wildfire, that's the source. Then, of course, there are the emissions, the smoke, but it's actually then the concentration that's measured either outdoors or indoors. The exposure of people depends on whether they're outdoors or indoors. And oftentimes with outdoor pollutants, people spend about 90% of their time in modern America indoors. So when we use outdoor concentrations, we have misclassification of exposure right off. And what really matters for biological effects, health effects, is the dose. And that's what reaches the target organ, which is often the lungs. But since there are a lot of cardiologists on this webinar, what gets into the lungs, then some of it gets transferred into systemic circulation and reaches the heart, but not all. And then, of course, we're worried about health effects. So how is air quality regulated in the US? The California Air Resources Board, and I'm the physician member of the California Air Resources Board. The California Air Resources Board actually predates the US EPA and the Clean Air Act. Since I'm a member of the California Air Resources Board, I like to brag about it. But in fact, who was governor in 1967? Ronald Reagan. But Ronald Reagan was from Southern California at the time, and he knew how bad smog was. And so he was happy to sign the legislation that caused the Air Resources Board to be established and provide the first smog controls on motor vehicles. Then the Clean Air Act of 1970 helped establish the US EPA. And again, who was president in 1970? Richard Nixon. And Richard Nixon was happy to sign this bipartisan bill to clean up the air in the US. And we've come a long way from that bipartisan approach to air quality. And then the Clean Air Act requires the US EPA to review the scientific literature every 5 years for each pollutant that it regulates, and it creates national ambient air quality standards. That controls the concentration of pollutants in our air that everybody breathes based on a review of the scientific literature, and basically has to show robust associations with public health impacts. So the EPA currently regulates 6 so-called criteria pollutants. They have to meet certain criteria. I'm only going to talk about 3 because of time constraints. And these are all important ones here in California. So the one in red I'll talk about. I'll just mention parenthetically, the EPA also regulates hazardous air pollutants. Those are carcinogens or reproductive toxicants like benzene or formaldehyde or asbestos. In California, we call them toxic air contaminants. I won't talk about those because they aren't regulated in terms of the general air quality for a region. They're regulated at the source. So a refinery that emits benzene in refining oil to gas has to get a permit from the local air quality management district to release a limited amount of benzene, for example. But these criteria pollutants have national ambient air quality standards that govern the entire country. Okay, so ozone is the most studied of all the air pollutants because it was the original bad actor in LA smog. It's what we call an oxidant pollutant, meaning it will donate electrons to any surface, including our airways. Its major source is motor vehicle emissions, but it doesn't come directly from the tailpipe. It actually, as I've mentioned, oxides of nitrogen and volatile organic compounds, which are released during the morning rush hour. Those compounds get cooked in the sunny afternoons by photochemistry and produce ozone. We know a lot about ozone health effects, both from epidemiology and controlled human exposure studies, and for that matter, animal toxicologic studies, including in rhesus monkeys. UC Davis has done a lot of work on ozone and rhesus monkeys. And I hate to tell you, but rhesus monkeys have a 99+% homology with our DNA. So rhesus monkey lungs are a good model of human health. So we know from experimental studies in humans that people exposed to ozone get respiratory symptoms. They have decreased lung function acutely, and they also get airway inflammation. And this occurs in healthy people. People with asthma have a risk for exacerbations, and there's even evidence that new onset asthma in children is related to ozone exposure, especially if kids play a lot of outdoor sports and get exposed to a lot of ozone that way. And this is just showing a child activating a meter dose inhaler. We have data that directly show that meter dose inhaler use is associated with ozone levels in asthmatic kids and adults. There's also some mortality data, which I don't have time to talk about. High ozone days, short-term, but also long-term high level exposure to ozone is associated with increased risk of death, and especially in older people with pre-existing heart and lung disease. I'm going to switch to a data slide here from a typical study. There are many of these studies that have shown ozone exacerbates asthma in kids. This came from Atlanta, and they showed that during the warm season in Atlanta, there's a pretty linear relationship between emergency room visits for pediatric asthma and concentrations of ozone. Now, an important point of this slide is the current ozone national ambient air quality standard is 70 parts per billion, which is right here. And you can see that there's a linear response below that. So I would argue, and the EPA is currently considering this, that the current standard isn't protective for kids with asthma. And this is just showing that over a lag time of days after a high level exposure to ozone, there's decreased risk. So it's really the day of a high level exposure to ozone, a bad ozone day, that there's the greatest risk for asthma exacerbations. So nitrogen dioxide is, as I've mentioned, a precursor to ozone. It's another oxidant gas. It's not as potent as ozone at burning the airways. And its major source is from combustion of fossil fuels. Motor vehicle emissions, sort of the biggest source in California, but power plants, including power plants in California. We don't burn coal in California, but we burn natural gas. That releases oxides of nitrogen. So a control strategy in California for reducing ozone is to reduce natural gas power plants, which we're trying to get away from in California. And it's also to have cleaner vehicles, including zero emission vehicles, which we're trying to do in California. So this just shows you the source apportionment of NO2, that it's mostly motor vehicles, whether they're on road or off road, like agriculture or construction. And it's a good marker of traffic emissions. It's often used as a proxy for traffic emissions. And the traffic emissions are more than NO2. They include fine and ultrafine particulate matter and various volatile organic compounds. So what do we know about nitrogen dioxide health effects? We know a lot about long-term exposures, and there's decreased lung function growth. And I'll show you this data figure from the Children's Health Study from Southern California, which was a landmark study where they followed over 4,000 kids from age 9 to age 18. They followed them through the schools, 4th grade through graduation high school. And each one of these dots, there's only 12 up here, maybe 24, relates to hundreds of kids in each community, in schools in that community. And so these are average annual nitrogen dioxide concentrations in those communities. And for both girls and boys, there's decreased growth of lung function with increasing average exposure to NO2, basically increasing traffic emission exposure. And again, this annual average goes up to 40. The current National Ambient Air Quality Standard annual average is 53 parts per billion. So I would argue that kids, and these are not kids necessarily with asthma or other respiratory disease, mostly healthy kids, have decreased growth of their lung function during their teen years. And like ozone, there's also data about NO2 leading to exacerbations of asthma and perhaps new onset asthma as well. Now, I've mentioned NO2 as a proxy for traffic exposure. Sometimes the epidemiology just looks at traffic exposure, like traffic density or distance of a child or adult's home from busy roadways. And so decreased lung function growth in the Children's Health Study was shown just in relation to traffic density without specifically NO2. And here's a slide showing that data. Again, this is from the 4,000 kids they followed between age 9 and age 18, and they were all enrolled without pre-existing asthma, but about 400 of the kids developed asthma while they were being followed. And these are the risk of that development of asthma, new onset asthma, relation to traffic exposure, both at home and at school, and then the combined risk. And you can see there was a substantial risk of exposure, traffic-related exposure, and new onset asthma. So I want to shift to ambient particulate matter, which will be the focus of our discussion of wildfire smoke. Not that there aren't other pollutants in wildfire smoke, but we know the most about Wildfire-PM 2.5. So I'm going to be talking about non-Wildfire-PM 2.5 on this slide. And this is a US EPA cartoon showing a human hair, which is about 60 microns in diameter. The yellow spheres are PM10, 10 micron or smaller particles that make it down past the vocal cords. And then the blue spheres are fine particulate matter that's less than 2.5 microns, makes it down to the deep lung, the alveoli. And then the little red spheres are ultrafine particles, less than 0.1 microns, and they make it into the systemic circulation. So PM, unlike ozone and NO2, is a mixture, has particles of differing origin. All around the world, including the US, they're regulated by particle size. There are multiple sources. The really fine ultrafines come from combustion, including biomass, wildfire smoke. PM 2.5, usually from fuel combustion, fossil fuels, but also biomass. And then PM 10 to 2.5, those are bigger particles. They make it to the airways, have more of a risk for asthma, COPD, and these particles are from road dust, from the Earth's surface, like in a windstorm. Those of you from the Central Valley know about windstorms and dust storms, and then biological material, including pollens, fungal spores, etc. So the health effects of particulate matter. And again, we have volcanic eruptions and we have coal-fired power plants, to give an example of so-called natural, so-called man-made. Just like ozone and NO2, there's good evidence for exacerbation of asthma and some evidence for new onset asthma, decreased lung function growth from the same Children's Health Study and others. And then mortality is the big one, so-called killer particles, and especially ischemic heart disease. And then there's a fairly good literature for PM 2.5 and lung cancer. The International Agency for Research in Cancer, IARC, has listed PM 2.5 as a class 1 carcinogen. And now this is the mother of all time series studies with regard to particulate pollution and daily mortality. There are many such studies, but this one was supposed to be the end-all be-all one. That's why it got published in the New England Journal. And 26 countries, 652 cities, and millions of deaths. And this slide shows the PM 2.5 concentration on the x-axis, and then basically the mortality risk. And it's got various standards, air quality standards. The World Health Organization has very stringent guidelines. This is actually, they've just updated them, but for their 24-hour daily standard, at the time was 25 micrograms per meter cubed. The US had a 35 microgram per meter cubed standard. And you can see that even below these standards, there's still a risk. And the US EPA is currently reassessing whether there should be a stricter standard in the US. And I would argue these data suggest there should be. Now, Susan Ivey actually, in preparation for, or as part of their of the grants analysis of the existing literature, came across this umbrella review of systematic reviews and meta-analyses. There are hundreds of studies that have linked PM 2.5 and all-cause mortality, but also cardiovascular disease mortality and other cardiovascular disease outcomes. And so this slide is just a strength of evidence summary. And wherever it says sufficient, that means 80 to 100% of the systematic reviews and meta-analyses that have been published showed either a short-term or long-term effect for either PM or oxides of nitrogen. So you can see there are better data for PM than for NOx, but there's a substantial amount for NOx as well, and including multiple outcomes like blood pressure, heart failure, arrhythmias, et cetera. So now let me pivot to wildfires, the main focus of today's webinar. And as I think everybody from California and other states in the Mountain West knows, there's been a major increase in acres burned by wildfire. This is total acres burned, but if I showed a different slide of mega fires, catastrophic fires, those are also going up, actually more strongly than the total acres burned. And again, for those of you from the Pacific Northwest, this is a satellite view of the smoke plume. This goes from Southern California, I think the Mexico border, all the way up to British Columbia. And you can see there's just terrible air quality. This is 2020. Dr. Balmes was referring to last year, 2021. I'll get to that. 2020 was actually worse in terms of air quality for a larger area of Northern California and the Pacific Northwest. Every one of these red dots is a wildfire. It was just crazy. So staying with 2020 for a while, 3 of the 5 largest wildfires in California history occurred in 2020. This slide used to say 4 of the 5 largest wildfires, but then we had the Dixie Fire in 2021, which is now the largest wildfire. The August Complex fire was the largest fire. It burned from August into November, burned over 1 million acres. They just let it burn for the most part because it was in the middle of nowhere. Excuse me for anyone who lives in Mendocino County. Anyway, the California wildfires in 2020, in 2018 burned 1.7 million acres. We had 4.1 acres burned in 2020. 2020 is still slightly worse than 2021 in total acres. 2021 was just about 4 million. Over 10,000 structures were damaged or destroyed, and there were at least 31 fatalities. Now, it's not just the US. Australia, that same fire season, theirs was this, our winter of 2019, 2020 was their summer. I deliberately show this photo that shows a kangaroo because millions of koala bears and kangaroos died, including other animals during these wildfires. So I said there were 4+ million acres in 2020 burned in California. There were 46 million acres in Australia, including in populated areas. They lost less homes than we did in 2020. And this is a satellite photo of one of the worst days of their fire season. It's so bad you can't even see New Zealand. I just, as an aside, the Australian Open was being played during this bad fire season. And I got a call from the Australian Broadcasting Corporation about whether it was safe for tennis players to be playing those, long matches, like the Nadal-Djokovic match, where they go on for 5 hours. It was 100 degrees temperature and there was bad air quality. And these healthy athletes were having symptoms. And to remind me to tell you that not only are these wildfire emissions bad for our health, they're also bad for the climate. Black carbon in particular is a climate forcing agent. So the Australian Environmental Protection Agency estimated that the emissions from those wildfires were equal to 12 months of man-made greenhouse gas emissions. Just to bring us up to date, in California, as Dr. Balmer mentioned, we had terrible fires. South Lake Tahoe had to be evacuated because of the Caldor fire and the Dixie fire, which was still burning while the Caldor fire erupted, took out the town of Greenville and is now the largest wildfire in terms of acres burned in California. So why do we have bad wildfire years in California at any rate? This is 2019, which was a good wildfire season with a lot of snowpack in the Sierra. And this is 2020, where there's hardly any snow. And there's even less snow this year. So I expect for us to have a bad wildfire season. Again, in addition to causing air quality problems and health impacts, there's a feedback loop where the wildfire smoke has climate forcing effects. So it actually adds to the problem. What are the emissions from wildfires? There's primary pollutants, particulate matter, carbon monoxide, oxides of nitrogen. When anything burns in our nitrogen-rich atmosphere, you generate NO2. Polycyclic aromatic hydrocarbons, PAHs, are nasty compounds. They're some of the carcinogens in tobacco smoke. And then volatile organic compounds like benzene, formaldehyde, acrolein are also present. I like to think of wildfire smoke as tobacco smoke without the nicotine. That's not a bad analogy, actually. And then there's secondary air pollutants. There's a secondary aerosol generated from the primary pollutants in the atmosphere, and then ozone is generated from the NO2. The campfire and November 2018 was a disaster, took out the town of Paradise. The reason I'm showing this is this is an example of a wildland urban interface fire where it's not just vegetation that's burning, it's cars and buildings, and cars and buildings give off particularly toxic compounds. And that's why structural firefighters wear Scott air packs. So people who are immediately downwind from, including the firefighters, from these WUI wildland urban interface fires have particularly heavy exposures. I was involved with a critical review of health impacts of wildfire smoke exposure. These are community health impacts. In 2015, it was funded by the British Columbia CDC, because British Columbia has the same kind of problem with wildfires as we do in the Pacific Northwest of the US. This photo wasn't part of the review, but I like to show it because, and Stephanie will get to this, there's something wrong with this photo. You could see the smoke in the background. The family's all wearing N95s, but should they be out when there's this kind of wildfire smoke? This was the Thomas fire. This is Santa Monica. The Thomas fire was the fire in December of 2017, during which Jerry Brown said this is the new normal for California. And Stephanie will talk about respiratory protection for kids in particular. So what we learned from that critical review of the literature was almost every study showed asthma exacerbations. There's really no doubt that wildfire smoke can exacerbate asthma, probably COPD as well. And when we did the review, we saw growing evidence of link between wildfire smoke and respiratory infections. And I would say the subsequent literature has pretty much nailed this down. This is a slide from Colleen Reed, who was my doctoral student at the time, study of the 2008 Northern California wildfires. Those of you who are a little bit older might remember that that was a bad year for wildfires. No catastrophic fires like we've just been talking about, but there were a lot of smaller fires, and there was a air inversion for many days. It was also very hot, so there was a lot of ozone too. And Colleen was able to show that there was increased PM 2.5 during the wildfire period from late June to late August. And there was an increase in asthma healthcare utilization. Surprise, surprise. And here's a slide from a study from Harvard investigators that showed that in 92 counties in Washington, Oregon, and California, there was an excess of COVID-19 cases. So these are cases of infection, SARS-CoV-2, and deaths due to COVID in relation to wildfire-specific PM 2.5. How do they get wildfire-specific PM 2.5? We have satellite data for the baseline PM 2.5 in non-wildfire periods. And then you can look at the satellite PM 2.5 where there's a smoke plume. It's two different satellite platforms. And then you can subtract the baseline from the peak PM 2.5 in the smoke areas. And you can be, it's a pretty good way of measuring wildfire-specific PM 2.5. This is a hard slide to read, but I want to make a point here. Alameda County, where I am currently, was kind of, there was no increased risk related to wildfire smoke in terms of cases. But look where Alameda County is in terms of deaths due to COVID. And I would posit that this is in part due to the demographic characteristics of Alameda County, and it's evidence of low-income people of color having increased risk for bad COVID outcomes. So in addition to respiratory outcomes and respiratory infections, there's increasing evidence for wildfire PM 2.5 exposures and cardiovascular healthcare utilization risk. And I like to highlight this study because it was actually led by a UCSF medical student, Zach Wetstein, during he took a year off of his from medical school to do this work in collaboration with the California Department of Public Health and the US EPA. And they use the same kind of satellite wildfire specific PM 2.5 exposure assessment that I just described for the COVID study. And this slide shows that they got the expected increased respiratory healthcare utilization effect, but they also had a cardiovascular effect as well, especially in older folks. And this was the 2015 wildfire season, which by today's standards is not even a particularly bad one. Now, this slide is from that August into early September 2020 period where we had very bad air quality in all of Northern California. So you can see there are 4 Northern California metropolitan areas, and then LA, Long Beach, Anaheim as a sort of comparison. Now, the 0 on all these graphs is not 0 PM 2.5. It's the baseline from 2015 to 2019, baseline average. So Fresno, which is one of the more polluted cities in the country in terms of PM 2.5, this isn't 0. It's already above the federal national ambient air quality standard. So wherever there are red peaks above the 0 line, that's in excess of the average. And so you could see there were really high peaks. And Marshall Burke from Stanford has estimated, based on the robust concentration response data. I showed you one of those slides, that mother of all 652 city New England Journal paper, that we have very robust concentration response functions for mortality. And so he estimated 1,200 to 3,000 excess deaths during that bad month, where here in the Bay Area Air Quality Management District, 9-county area, we had 30 straight days of spare the air days. So outdoor workers, like agricultural workers, are now protected theoretically by an emergency standard of CalOSHA. They have to be provided N95 mask when the air quality index gets above 150. And that leads me to the occupational exposure of greatest risk, wildland firefighters. Many investigators, including me, have shown cross-shift changes in lung function, biomarkers of exposure, and blood biomarkers inflammation just across the 12-hour shift that most wildland firefighters fight during a bad fire. There's also across season changes. I was involved in the study where we measured US Forest Service hotshot crews lung function, airway responsiveness before the fire season when they first mobilized, and then at the end of the fire season when they demobilized. And we found cross season decreases in lung function and increases in airway responsiveness. What we don't know, though, is during the off season, whether these effects go away. So do the fire season associated changes persist as an unknown question right now. But we know enough about exposure. And again, we have concentration response function data for both lung cancer and cardiovascular disease mortality. So I participated with Kat Navarro, my former doctoral student, to do a risk assessment. So this is not real data in terms of health risk. It's a risk assessment. So we know how much smoke wildland firefighters inhale when they're fighting fires. And we know how many days on average they fight fires, though that's going up with increasing acres burned. And we know we can estimate career durations. It's not all seasonal. There are career wildland firefighters. And so we showed increased risk for both lung cancer and cardiovascular disease mortality. Now, this is increased risk. There are no data that actually show that wildland firefighters have these increased risks. But it's cautionary. So last few slides before I hand it over to Stephanie. So fire suppression has increased fuel availability. The US Forest Service used to have a mantra that a lightning fire in the forest would have to be put out by 10 a.m. the next morning. So we were doing that for decades. So there's a lot of unburned fuel in our forests. That's one thing that I sort of agree with President Trump about. He said we had to rake our forest. Well, actually, raking wouldn't do much, but we have to clear the brush on the forest floor by prescribed burns or mechanical clearing to reduce risk. We also have to stop developing in the wildland urban interface. This is a photo from the Thomas fire that I mentioned before in 2017, which came close to taking out whole neighborhoods in Montecito, in Santa Barbara area. Most of the US Forest Service wildfire budget goes to suppression activities to put fires out. There's precious little for necessary forest maintenance, either prescribed burns or mechanical clearing. The 2013 Rim Fire started in Yosemite. That used to be the biggest wildfire that we ever had, but mostly burned in the Stanislaus National Forest. Why? Because the Park Service had enough money to do forest maintenance, but the US Forest Service couldn't do the maintenance in the Stanislaus National Forest. Dead trees and excessive undergrowth need to be removed from our forest. Communities near national forests resist prescribed burns. We have to talk people out of that. And we need to put power lines underground so PG&E doesn't start more fires. We have to have at-risk communities do more to prepare for wildfires. This is the fire threat map for California. You can see a lot of the state is at risk. We need to bulldoze fuel breaks around neighborhoods, install new smoke detection cameras and sensors around towns like Paradise, remove vegetation around homes, improve escape routes and subdivisions so people don't die trying to escape on 2-lane dirt roads like in Paradise, train residents in initial fire suppression methods, which has been very effective in Australia. So in summary, the duration of the wildfire season is longer and catastrophic wildfires are increasing in frequency due to climate change. We know about acute respiratory effects, but now there are acute cardiovascular effects. We need to understand long-term effects of high and or recurrent exposures, especially in kids, which I'm sure Stephanie will talk about. We need to invest heavily in forest management and community resilience. Thank you.
Thank you, John. That was great. I do see one question teed up for John, so I don't know if you want to take that one now.
I'm fine if it's not going to be a time problem. Okay.
It looks like a short one.
Okay.
Has the children's health study shown any reversibility of the decrease in lung function growth?
Well, I couldn't have asked for a better teed up question. Yes, they've done follow-up studies, one of which got published in the New England Journal because it did show that as air quality has improved in Southern California, the same communities that they studied now have better air quality. There's still an effect on growth of lung function, but it's ameliorated. It's less dramatic than it was before. That's an excellent question, and I'm happy to give that answer. Yeah, there has been improvement in air quality in Southern California.
Thank you. And then I'm going to let you introduce your friend and colleague, Stephanie.
Yes, it's really a pleasure to introduce Stephanie Holm, who, as she mentioned, or as I guess somebody mentioned earlier on, she's a pediatrician as well as an occupational environmental medicine physician. She's double boarded. She also has some specialty training in pulmonary pediatrics. She has an MPH and a PhD in epidemiology at UC Berkeley. I was fortunate enough to be her advisee, and she taught me as much as I taught her during that period of time. And I'm happy to say that we remain colleagues now that she's on the faculty at UCSF in occupational environmental medicine, where she co-directs the Western States Pediatric Environmental Health Specialty Unit. And she's also a physician at the California EPA in the Office of Environmental Health Hazard Assessment. And she knows as much about respiratory protection with regard to wildfire smoke for kids as anybody in the country. Stephanie, take it away.
Thank you, John. All right. Well, it's always a pleasure to get to speak with John because he does such a nice job of giving the background that I can just jump into the part that excites me the most. So thanks for the intro. As John said, I work at UCSF as well as at Cal EPA, the Office of Environmental Health Hazard Assessment, and collaborate with some folks at Berkeley as well. No financial relationships to disclose, but because I am lucky enough to be employed by a variety of folks, including the Western States PACU that's funded by ATSDR and federal EPA, and that I work for Cal EPA, I always have to have my disclaimer that my comments are my own and not official stances of any of those various organizations that I am lucky enough to be employed by and or funded by. All right, so since John gave some really excellent background on ambient air pollution generally, zooming in on wildfire smoke specifically, and also talking about health effects in adults, wrapping up with some policy considerations and community level interventions to improve wildfire smoke health effects. I get to now zoom in on why are children especially vulnerable, talk about the health effects of wildfire smoke in children, and then talk about sort of public health considerations and more individual level things that you can do or that you can advise your patients to do in order to decrease the health effects of wildfire smoke. I always like to start with this image on the right. This is actually one that I took in that 2020 wildfire season that John was talking about earlier, where we had, just a huge number of days in the Bay Area where we were blanketed by smoke. I like to call this the day that things looked like Mordor. Funny enough, the air quality that day actually wasn't that bad at ground level, but we had this huge smoke plume up above us that was really blocking out the sunlight, and the sky was red for much of the day. All right, so often when I'm talking to audiences of lots of folks that take care of adults, I give the standard pediatrician disclaimer that children are not small adults. But I also like to sort of joke they're still human, right? So a lot of what you all know about adults is applicable to children. What we'll do is we'll talk about the ways in which kids are different, so that you can feel a little bit more comfortable thinking about kids and their risk from wildfire smoke as well. Even if you never take care of kids clinically, I'm sure many of you either have children, know children, have neighbors that are going to come up to you and ask you about their children. So, hopefully this will be helpful. And then the prevention stuff is applicable to everybody. All right, so why are children more vulnerable to environmental exposures generally and wildfire smoke specifically? So the first is that children have differences in their physiology that increase the dose of an exposure that they get. So for the example of wildfire smoke, children breathe more relative to their body size, right? Their ml per kilo minute ventilation is higher compared to adults. And so they're going to effectively get a higher dose of anything that's airborne, and that includes wildfire smoke. They also have unique windows of growth and development. John mentioned earlier the studies from Los Angeles, the Children's Health Study, looking at lung function growth. And, that's very different than when we look at effects in adults. If you have a growing system and you perturb a growing system, you can have these long-term effects because of the disruption in the growth, as opposed to, effects that are in a more static system, to the extent that any system is totally static, but you get my point. And then children have behaviors and preferences that increase their exposure. So the one I always say for wildfire smoke is that kids tend to be outside running around playing more than we adults who are sitting here at desks. That's a good thing overall, right? We want our kids out and playing, but because they're outdoors, more active, breathing heavier because of it, they're much more likely to get more smoke exposure. So those are the three things, any environmental exposure that you're thinking about, those are sort of the three things to frame to think, why would kids be different? Why would their exposure be different? All right, so John talked about wildfire smoke effects as well as ambient air pollution effects sort of generally and mostly in adults, although he mentioned some children's effects as well. This is my sort of summary slide to say that we know a lot about air quality and air pollution health effects in kids just from ambient air quality. And sort of in all 4 of these areas, we know that there are substantial respiratory health effects for children. That includes things like asthma, as well as respiratory infections, metabolic and growth effects. That includes things like effects on hemoglobin A1C, effects on BMI from long-term air pollution exposure. There's some evidence of neurocognitive effects as well. I just worked on a study with John and some other colleagues at UC Berkeley recently looking at prenatal exposure to PM 2.5 air pollution and showing some differences in childhood IQ. And then, as John mentioned, PM 2.5 in particular is a known carcinogen. And so there are long-term cancer effects. Obviously, children have sort of a longer lifespan left. And so, there's always the concern that exposures in childhood could have lifelong effects and increase your lifelong risk of cancer. Hey, John, will you mute yourself when you have a sec? All right, so what do we know specifically from studying wildfire smoke in kids? There are a number of good studies looking at upper respiratory effects. I think this is not at all surprising to anyone that's lived through a wildfire smoke event, right? So there's lots of upper respiratory effects, itchy eyes, sneezing, sore throat, upper respiratory infections as well. And these things really go up in a dose-dependent fashion, right? So the more kids are exposed, the more likely it is that they have these symptoms. There's also a lot of good data showing an increase in asthma exacerbations in kids, specifically related to wildfire smoke. And this is one of those areas that's been studied in enough detail that we're starting to really explore who the groups at highest risk are. And it seems to be especially a problem in children with higher BMI and in younger children, including some of the kids that are young enough, we might not even consider them to have asthma, but be sort of our young preschool wheezer kind of phenotypes. And then there's also a study recently that showed that some indigenous populations may be at particularly high risk. Also good evidence for lower respiratory infections, that's things like pneumonia, bronchitis. And if you look at respiratory healthcare utilization generally, I have ED visits here, but also hospital visits, clinic visits, those also go up in children in association with wildfire smoke exposure, especially true in the younger kids, as I said, some of whom we might not even consider to be kids with asthma. And there's a really interesting paper in the last couple of years showing that Wildfire-PM may be a particularly strongly associated source of PM with respiratory ED visits in kids. And then I have on here just as a, one other paper to mention, much of the evidence is for respiratory effects, but we are starting to see increasing evidence of other health effects in children. There's a UCSF UC Berkeley Joint Medical Program student a couple years ago who worked with John and I and showed that atopic dermatitis, and he worked with a lot of people, just to be clear, including John and I, who showed that atopic dermatitis visits at UCSF increased in association with wildfire smoke exposure during the Camp Fire in 2018. There's also pretty robust data looking at some effects of wildfire smoke exposure in utero. So pretty robust data showing decreases in birth weight, both if you look in terms of, sort of birth weight as a continuous variable, or if you're looking at whether there are increases in low birth weight or very low birth weight infants. There's also some evidence of increases in preterm birth associated with wildfire smoke exposure during pregnancy. Those seem to be strongest for late pregnancy. That exposure in late pregnancy is particularly problematic. And then there's also some evidence that there's increasing gastroschisis. That's for those that haven't thought about kids and infants for a long time, that's those abdominal wall defects. And those are associated with exposure in the preconception and first trimester period. All right. So John presented, some really great data looking at overall mortality. I think folks often forget that child mortality can also specifically be related to wildfire smoke. It's forgotten because, childhood mortality is much more rare than older adults. That's a good thing. But if you look worldwide, there's actually still a sizable number of children's deaths that can be attributed to wildfire smoke exposure. And so I think, that's just an important thing to keep in mind. All right. We're going to pivot and talk about public health responses and messaging. As Susan said, it's really important to have lots of clear communications for folks. It's one of the focuses of the grant that I'm getting to participate in with her. I also work, as John mentioned, at the Western States Pediatric Environmental Health Specialty Unit, and we have a number of wildfire smoke related things that we've released in the last couple of years, trying to improve communication. This is one example of something we've released, which is a little infographic, 3 tips for keeping yourself healthy during wildfire smoke events. One is to stay inside if there's smoke inside, and to create cleaner indoor air. And then if you can't avoid smoke, to select masks that provide the best protection. So I'll go over those things with you guys. So the first thing is how you know whether air quality is bad. Many of you may be familiar at this point with the air quality index. It used to be that when I gave these talks, a lot of folks actually hadn't heard of the AQI, but more and more, especially when I give talks within California, we've had, as John mentioned, such bad wildfire seasons the last few years. Folks are actually much more familiar with this. The scale goes from green up to maroon, good, moderate, unhealthy for sensitive groups, and getting worse from there. One thing that many folks don't realize is that those national ambient air quality standards that John mentioned are how this scale is determined. And so there's short-term standards and there's annual standards, and those are the cut points between the lower levels of the AQI at least. So this is an example of if you go to airnow.gov and how you can get your air quality information for your local area. If you're, advising a patient, or as I used to say, my grandma, giving people information about how to find something, you want something that's sort of simple and really easy for people to understand. This is a good webpage to direct folks to. It'll show you, for example, the day I took this screenshot, the air quality in San Francisco was good. It's got the overall green color. It's showing it on a little sort of, odometer or speedometer style dial. If you clicked over here, it's got a little legend to remind you what each of these colors look like. And it also gives you a forecast of today's air quality and tomorrow's air quality. So that's sort of, simple, straightforward. If you want something easy to show people, that's a great place to direct them. If you want some more detailed information, there's a fire.airnow.gov webpage that the EPA started putting together, I think 3 years ago now, as a pilot project. And it's really cool because it combines sources of information. So that page that I was showing you a moment ago, the sort of most simple, straightforward one, uses information from the government regulatory monitors. That's really sort of the gold standard information. It's really high quality, it's quality controlled, it's collected with the most expensive equipment, et cetera, et cetera. But there aren't as many of those. And so if you look on this map, these circles are the high quality government regulatory monitors. The squares are low cost monitors, in this case, purple air monitors. And so what this map does is it's combining information from two different kinds of sources. And so it can give you some better spatial resolution. So for example, at the time I took this image last July, you can see that in Chico, the regulatory monitor was picking up PM 2.5 readings in the yellow, that's the moderate range. This one up just north of Paradise was picking up things in the red, that's the unhealthy range. And if you didn't have any of these lower cost sensor data, you might not know sort of where in this range becomes problematic. If you live over here on the east side of Chico, is it still in the yellow or is it in the red here? So you can get some more granular data by looking at this kind of a map. Again, it's combining multiple sources of information, so it's definitely more useful for folks who are a little more comfortable looking at data. If you click on one monitor in particular, so I picked this orange one in the middle here, it's unhealthy for sensitive groups. When you click on this, it shows you, again, what the current is. So it's orange, shows it to you on the little speedometer thing. It also shows you the trend. So it's saying, look at this monitor, things have been getting worse. It's headed toward the red. And if you go down on these little dots on the side here, it gives you more information. So for example, if we click down to the trend one, this shows you measurements at this sensor over the last 30 minutes indicate that it's increasing toward the unhealthy range. So that's really helpful if, you're trying to decide whether to do something, take your kids to the park, whatever. It gives you a sense of, are things getting better? Or are they getting worse? I often get questions about the purple air map, so I'm showing this just because I get questions. I don't have any affiliation with them, and I'm not necessarily recommending their products. But people ask, they'll say, I mentioned that on this map, these little squares are purple air sensors. Why can't we just use the purple air map? And there are a few differences that are important to know about the purple air map. One is that the default on here is purple's own correction factor, which is less accurate. The one that's used on the fire.airnow.gov map is an EPA nationwide correction factor that was developed specifically for wildfire smoke. You can select that on this map. So if you know to look for the conversion factor, and I think actually they've just changed their interface, so it's up at the top now. But anyways, you can change it to the USA EPA correction factor, but that's not the default. Another difference is that there's a lot less quality assurance done on these. So the fire.airnow.gov does a number of sort of automated checks on the sensor data. And if the sensors are failing those checks, it will take them off the map. That doesn't happen on this data. The averaging time here is shorter. That means that if you have really short-term aberrations, little blips in the data, those will show up on this map. So the example I often give is, these low-cost sensors are placed anywhere someone wants to put them. So if I happen to have put it on my patio, for example, and there's a truck that stops right next to it and is idling, that's going to show up on my sensor if you're looking at a 10-minute averaging time, as is the default on the purple air map, whereas it won't on the fire.airnow.gov that uses the sort of standard EPA averaging time, which when things are changing quickly, the shortest possible averaging time there is 1 hour. And then the other thing is that colors here are much less perceptually uniform. So I don't know if you remember, I showed you this sensor up above. It was orange. Part of the difference there is that the averaging time is shorter. But the other thing is that, you'll notice this looks like a very deep, almost maroon kind of red, as opposed to the bright red that's usually associated with the unhealthy level. And that's just because purple is using this gradient of colors. And so the way our eyes perceive it is actually slightly different. Another good example is that these two here, 74 and 92, are still within the moderate range, not the unhealthy for sensitive groups, so that those should be yellow. But at least to my eye, those look very orange. Just some examples, I know I often get asked, and I've heard from other physicians that people will ask them, how do I know which low-cost sensors are precise? And I specifically say precise rather than accurate, because even the best ones need appropriate conversion factors. So what you're really looking for is that something's precise, that if the PM 2.5 levels go up, that it goes up. If they go down, and that it tracks well. There's a really nice webpage, AQ Spec, that's run by the South Coast Air Quality Management District in Southern California. And they've done a lot of testing on various low-cost sensors. What I've given you on the right here is a QR code to their page. They test a variety of sensors. So, if you or your patients ever say like, oh, well, is this a good one? You can look and see if they have tested it. And what you're looking for is the R-squared, how well it tracks with gold standard data. Here are two examples of ones that have tested well. So I mentioned the purple air, those are stationary sources. And then there's also, this is another example of one that's more portable. Again, I don't have any relationships with anybody, just pulling these from AQ Spec data. AQ Spec does both lab and field tests. So they'll test them, in a tightly controlled lab setting. And then they also have this outdoor sensor enclosure that they use, and they assess, how linear it is, how the data trend, how accurate, how precise they are, response time, all of those kinds of things. But one of the most useful things that they report is an R-squared. If you think way back to your elementary statistics, right, that's telling you how much of the variability in the gold standard air quality measurement, one of those government reference monitors, how much of that is captured by the low-cost sensor. And so you want a number that's closer to 1. And so what I've done here is I just pulled as of, I didn't update that date. Apologies, I just did this last week. So as of last week, which sensors on AQ Spec have an R-squared greater than 0.85 for at least one or more of the fractions, and which ones are less than $500. So, you could scan through and do this yourself at any point. But, you can see that right now there's, more than 10 that fit those criteria. So there are definitely ones out there that can give you precise information. Still understanding the limitations. All right, so once you know whether air quality is a problem, what are the steps that you can take to protect yourself, your family, your patients? So the most important thing is to make a cleaner indoor air space. And when you think about what affects how much of outdoor PM, that's true for ambient PM as well as wildfire PM, how much of it comes inside, there are really three things that contribute. So the first is mechanical ventilation, right? So that's if you're running an HVAC system, you're intentionally pulling air in through some sort of fan, that kind of thing. That's one way that air comes inside. The second is natural ventilation. So that's, opening your windows, opening your doors. And then the third is infiltration. So that's the idea that even if, you thought you had sort of totally sealed your house up, right? If you'd closed all the windows, closed all the doors, shut off the HVAC, there's still some outdoor air that comes in through the leakiness of the building envelope, as it were. And so sometimes the, gut reaction of folks, if there's smoke outside, is just like, well, outside is bad, so close it all off, right? Like shrink wrap my house, make sure nothing new comes in. But the problem is that if you stop all of those methods of airflow, you'll actually have problems with pollution that's made inside. So, we as humans do a number of things that create pollution indoors. Anything that burns, right? Whether that's candles, incense, fireplace, any of those kinds of things. Cooking creates indoor air pollution. Lots of hobbies, so anything that uses paint or various kinds of chemicals can produce volatile organic compounds. So you'll have problems with indoor air pollution, and then you can also have moisture and mold problems if you've really shut down airflow. And so one of the key things to think about is that really what you want to do is change the proportion of air coming in that's filtered. You really want to make sure that you're filtering as much of the air as possible. So if you have central air, if you have an HVAC system, the best way to do that is to pick a filter that's rated MERV 13. MERV stands for minimum efficiency rating value. It's the sort of standard metric by which filters are rated. You want that to be MERV 13 or higher. And then if you're getting a portable air filter, either because you don't have an HVAC system or to supplement your HVAC system, you want to make sure that it has a high enough clean air delivery rate for your space. So you want it to move the air in the space 2 or 3 times per hour. And you want to make sure that it does not produce ozone. So many of the sort of electronic or ion-based air cleaners produce ozone and produce ions. And many of those have been shown to have cardiovascular effects as well. Ozone for sure, and there's some suggestive data just for ions as well. And so you're really better to stick with the mechanical air filters. I mentioned a minute ago, the difference between ventilation and filtration, that ventilation is moving air in and out of a space. Filtering is really filtering the contaminants out of the air. There's data that both can improve health outcomes. So there's a nice study out of Lawrence Berkeley lab from a few years ago looking at some modeling in Southern California homes during wildfire events. And those folks showed that, oh, that didn't show up on my references, apologies. That's a Chan et al. Paper. That running HVAC continuously can decrease wildfire smoke PM 2.5 levels within homes by about 1/4, but that combining continuous running with an improved MERV filter decreases it much further. That interestingly, if you replace the MERV filter but don't run your HVAC continuously, that has much less of effect. So it's really important to make sure you're running the HVAC system so that you're pulling air through that filter, as opposed to having more of the air come in through infiltration and through natural ventilation. And then again, benefits for the portable air filter as well. Obviously, the best decrease in PM 2.5 from wildfire smoke was the combination of MERV 12 with continuous HVAC and a portable air filter. And that decreased the exposure by about 62%. In schools, there's been associations with improved ventilation in terms of looking at overall absences for children, and also benefits with math and language performance when there's been improvements in ventilation. So going over to the filtration side for a minute, and I think this might have been one of the things that John was hinting at earlier when he said I would cover stuff, is that filtration is really one of the key benefits. Being indoors in a cleaner indoor air space during wildfire smoke is the key intervention that can have really substantial health benefits. The only study that I know of that compared directly being indoors in a cleaner indoor air space to just leaving the area, right? Some people are like, oh, well, no problem, I'll just leave the area. That seems like a really tempting thing to do, or using some sort of mask or respirator. The only one that showed a difference in health effects was actually being in a cleaner indoor airspace in your home. And, part of the reason for that may be that that's a much more sustainable intervention, right? It's hard to leave your home for long periods of time, especially if, for example, like in 2020, we had 6 weeks straight, right? It would be really hard to leave for 6 weeks, be in a hotel. That's cost prohibitive. It's also just really challenging to do your work and have your kids go to school and all of those things that you need to do if you're not in your home. There are also some studies out of British Columbia showing that doing a portable air filtration intervention in homes was able to decrease pollutants, PM 2.5 from wildfire smoke a little over 65%. That was, in the same homes doing both a sham and true filtration intervention. And then, as I mentioned, there are known benefits for improved filtration as well. I'm a pediatrician, so I'll often look at school things, but for this example, there's a decrease in asthma morbidity in Detroit schools that would be expected if you improve the filtration throughout the district. And there's evidence of higher test scores among students that go to schools with improved filtration. All right, so this is my sort of summary of things that you can do to help decrease air pollution exposure indoors. Reminder, if you have an HVAC system, you want to make sure that you're using a MERV 13 filter or higher. Some companies have their own sort of proprietary rating system, but you really want to look, they should all have the MERV, M-E-R-V rating on them as well. So that's what you want to look for. If you're using a portable air cleaner, you want to make sure it's the mechanical kind that has a filter like I'm showing on the left, and not an electronic or ion sort of kind. And you want at least 2 air changes per hour. The more you can do, the better. There's often a bit of a trade-off between noise level and how many air exchanges you can do. And then, there's been a lot of interest recently in DIY air cleaners. These use a box fan as well as some MERV 13 filters. So these same kind of filters that you would put in an HVAC system, but you can assemble these DIY air cleaners with those. In some cases, they can be much less expensive, and they actually have relatively high clean air delivery rates. In general, most of us in the field still recommend doing a commercial portable air cleaner if you can. There's better data on longevity of those devices, but that these are a useful option for folks that can't otherwise do portable air cleaners for whatever reason. There's a EPA page that was created actually as part of COVID response that has a nice set of references looking at different designs for DIY air cleaners. Some are made with 1 filter in the fan. I've seen designs with 2. I don't think I've ever seen one with 3. That geometry might be hard, but there's also this example here that has 4 filters. So different ways those can be assembled. The more filters you have, the higher clean air delivery rate, but also the more expensive it is, right? Because you're having to buy 4 filters in this example. Again, best option is to have a clean air space in your home if possible, but that's not always an option for all folks. If you're in California, the best way to know about cleaner air shelters is to know what air district you're in. Many of the air districts will put out information about clean air shelters when it's relevant in their community. So John, for example, earlier mentioned the Bay Area Air Quality Management District. Wherever you're located, it's good to know who your air district is. Local news sources often also have information on that. And I know there's a project at the California Air Resources Board looking at cleaner air shelters. So my hope is that sometime in the future, there may be a more centralized source for information. All right, so we talked about how to know how the air quality is, and then we talked about making a cleaner indoor airspace, because that's the sort of best intervention to protect yourself or your patients during a wildfire smoke event. But I also get asked a lot about mask and respirator use, and whether that can be beneficial, especially if you're in a situation where you can't be in a cleaner indoor space, you're transiting between places or whatever it is. So when we think about mask and respirator use for ambient air pollution or for wildfire smoke, there are really two things that you need to think about. The first is filtration, and that's how many particles can pass through the material of the mask or respirator. And then the second is leakage, how many can pass around, right? Sort of what's the leakage around the device between the device and the face. And if you think about all of the devices with this framework, it sort of helps you anchor things and think through what can work well for you or for your patients. There was recently a National Academies of Science, Engineering, and Medicine committee that was sponsored by NIOSH. NIOSH is the National Institutes for Occupational Safety and Health. And this committee was asked to determine the need for guidance on respiratory protection for the general public, as well as workers who aren't covered, and describe sort of options for how that could be done within the federal government, because historically there really hasn't been any guidance or consideration of the public and the public's need for respiratory protection. But between obviously infectious diseases, volcanic events, wildfire smoke events, there's a clear increasing need for guidance on these things by the public. So the report for this came out in February 10th. I served on that committee with a number of wonderful colleagues. And my hope is that, this will get incorporated into some things moving forward at the national level. Certainly, as healthcare providers, anytime there's an opportunity to advocate for, inclusion of these kinds of recommendations into the governmental structure, there's the potential benefit for our patients. As I said, this will ideally lead to some positive changes that could include development of new devices that are better for the public, some improved coordination of messaging at all levels within the US. I'm sure we've all noticed some gaps and conflicts in messaging, both for wildfire smoke events as well as during the COVID pandemic. As well as some increases in the evidence base, both for the use of respiratory protective devices, and that includes both their function and their safety, as well as best practices for communication, which, as Susan mentioned, is something that the project she and I are funded on are working on. And we as air pollution scientists and health providers need to continue to push for these changes. So that's my call to arms, as it were. But what do we know currently about masks and respirators and what's available to the public? Obviously, there are cloth masks, which may decrease the transmission of some infectious droplets. But I think it's really important to know and to understand that these really should not be relied upon to decrease PM 2.5 or wildfire smoke exposure more generally. For one thing, there is just a huge variety of filtration properties of cloth masks. That's true whether these are homemade cloth masks, like the ones in the photograph that I made for my family early in the pandemic, or commercially available ones. They're just huge varieties. And, I like to joke that's partially because it's not as though you can walk into Joann Fabrics or Michael's or your craft store of choice and say, yes, I would like the aisle with the fabric that filters 95% of particles. That isn't a thing, right? We don't regulate our fabric in that way. And the filtration property can be as low as 10% when things have been tested. And interestingly, in a couple of studies, including this one from Indonesia, some fabrics seem to actually concentrate PM 2.5 particles. So I think, one of the misperceptions is people are like, well, it's something has to be better than nothing. But that may actually not be the case for some fabrics. So, you really want to encourage folks to use something other than a cloth mask if they're trying to protect themselves from air pollution and from wildfire smoke. So what about medical masks or surgical masks? These are pretty variable. And the big reason for that is that there's a lot of leakage around them, right? So cloth masks, as we said, the filtration's not very good. So they both have a filtration and a leakage problem. Medical or surgical masks, the material itself actually filters fairly well, but there's a lot of leakage around the sides because these aren't tightly fitting. So mean decreases in exposure, depending on sort of who's testing it and how tightly it's been secured to somebody's face, can range anywhere between a 15% decrease to a 60% decrease. There's really only one study of children that I know of that's looked at medical masks. And this was one, those of you who've been in ORs are familiar with the masks that tie as opposed to having elastic kind of ear loops. So they used those tie masks on kids, had a nurse secure them pretty tightly, and found a decrease of about 65% in the children's exposure. But again, it's really a question of how tightly that's secured to the face. So what about respirators? Respirators are devices that are intentionally intended to decrease exposure to particles or other gases, depending on the type of the respirator. The ones that most of us are most familiar with are N95 respirators, which of course, many more folks heard about during the pandemic than knew about previously. One thing that's really different about using N95 respirators in the general public as opposed to using them among workers is that historically workers have had to undergo fit testing and some amount of medical evaluation for wearing N95s. And so, when we're thinking about their use by the public, you really are then thinking about how well can these things be used by folks that haven't been fit tested. And so there are a few studies that have looked at that. This is sort of a complicated result, so I'll go through this a little bit slowly. So this is a paper done by NIOSH looking at adults who had not been fit tested. So, similar to thinking about adults in the general public. And they took the information for all the people that had been trying this N95 without being fit tested and looked to see how much of a decrease in particle exposure they had. And the 95th percentile of that was 70%. So what that means is that 95% of the people had a decrease in their exposure of 70% or more. That was overall for the whole class of N95 respirators, although certain products did better than others. So some products had really low, the 95th percentile was as low as 10%. Some it was as high as 92%. So there's definitely the possibility here. I mentioned before the idea that we could eventually have products that are specifically intended for the public, intended for folks who aren't going to be fit tested. And there's the potential for, much higher benefit if we're specifically sort of selecting for those kinds of products. Since I'm a pediatrician, I always include the info about children specifically as well. Only a few studies that have looked at this, but the decreases seem to be similar to those in adults. The big change, of course, is that, or the big difference for children compared to adults is that there's a much wider range in facial sizes, and so you can have issues with the fit. And so it's, again, looking at how good of a fit you can get for children. Interestingly, many children, especially once we start talking about school-age children, sort of 6, 7 and up, have faces that are similar size as small adults, and so can get similar decreases in their exposure from using small adult-sized respirators. So this is an infographic that we at the Western States PACU made to try and just sort of help health providers think through how much of a benefit you can get from different kinds of masks or respirators. Cloth masks we didn't even put on here, right? Because you should not expect that you'll get a decrease in wildfire smoke exposure from those. But this is showing that if you're in a day that's in the unhealthy range, right? So, somewhere in AQI of 150 to 200, if you wear a medical mask, you would expect that it'll decrease your exposure about 20%. And so that'll either keep you in the unhealthy range or take you slightly into the unhealthy for sensitive groups, depending on sort of where exactly in that red range you are. But if you've got someone who's wearing a NIOSH certified N95, and the NIOSH certified point is important because the name or the N95 name is not trademarked, so that's how you know that it's a quality product that's passed the appropriate standards. You would expect sort of overall for people that's going to decrease exposure about 80%. Again, some variability depending on product and fit, but that if you use that 80% number, that's going to bring you from the unhealthy range back down into the moderate range. And of course, those of us that have been fit tested, as many health providers are, if you've been fit tested, you then expect the mask to be around 95% effective. And so, or decrease exposure about 95%. So that would bring you back into the good range from unhealthy. One of the things that often comes up is folks have a lot of concerns about mask and respirator use in the general public. One of those concerns is that, it gives folks a false sense of security or misunderstanding. They think that they can just throw their mask on, go out in an unhealthy air pollution day and run a marathon, right? That's not the case. Certainly you can get some decrease in your exposure from using certain kinds of masks and respirators, but that does not mean you should increase your activity level. And it still means you should still minimize the time that you're outdoors. So that image that John showed earlier of the family wearing respirators with, fires visible in the background. Certainly it's possible they were just skidding between, their house and someone else's home that had a clean airspace. That would be a allowable reason to do that, right? That would be a good reason to try and get some protection, but especially for the children in those family, it'd be more likely that they have some leakage around those N95s. And so if they had a cleaner airspace at home, they'd be much better to stay put and stay in that space. The other one that people worry about is safety. As I mentioned, healthcare providers and other folks that use respirators for work often have some amount of health clearance that they go through. And so folks wonder then, if I'm recommending these in the public, how safe are they? Most of the work has been done in adults, and in healthy subjects, there's really generally either no change or very minimal change in physiologic measures, things like heart rate, respiratory rate, when wearing an N95 respirator as opposed to not. But there are subjective changes. Folks, feel that their face is hotter. Sometimes they feel a little more uncomfortable. There hasn't been a lot of work in folks with substantial respiratory disease, but in cohorts of folks that include those with mild respiratory disease, again, people have some mild discomfort, but the objective measures like heart rate, respiratory rate, spirometry, spirometric values, all are within normal adult ranges. That's similar for children, fewer studies there compared to the studies in adults. But again, kids doing, various kinds of tasks, whether that's walking, running, playing, there's some differences in subjective symptoms, not liking the way that the respirator feels, but that if you look at the objective measures, even if there are slight changes, those stay within normal limits or generally within normal limits for children. Thinking specifically about pregnant people, the data on the effect of respirators on pregnant people specifically are mixed, sort of, whether it can increase heart rate and respiratory rate and those things. But there is good data showing that there are no effects on the fetal heart rate. So, it may make it more challenging for the pregnant person, but not specifically for the fetus. I think that's a useful thing to remember because it means you can, sort of judge the vitals of the pregnant person and their comfort level, and not worry that if they're comfortable that the fetus is having problems. All right, before I wrap up, I mentioned earlier that we at the Western States PACU have a number of wildfire smoke resources. This is a QR code to, I actually don't remember if it's our main page or our wildfire smoke page. It's one of the two. If it's our main page, you can go to one of the tabs and pull down to wildfire smoke specifically. And we've got a number of infographics there, some fact sheets about protecting yourself or your children or your patients from wildfire smoke, as well as more detailed information on mask and respirator use. We also have this, which is an additional continuing medical education course that's available. We've got not only CME credits, but nursing education credits and community health worker education credits and a whole bunch available there. This is called Sophia's Story. It's one of our chapters of our Story of Health series, which weaves narrative storytelling in with rigorous scientific information to help in sort of a case-based format, think through, or story-based format, think through wildfire smoke and how it can affect, in this case, a child and her family, and give you lots of information there, lots of ability to kind of dig into different pieces of that as you're interested. And then this is my standard goofy slide when I'm talking to adults, which is that, when you grow up, people stop asking what your favorite dinosaur is, and it's like they don't even care. And so, even if you think that children aren't your thing, we pediatric people are a lot of fun, and I don't want you to forget that. All right, so quick wrap up. Kids are uniquely vulnerable to increased wildfire exposure. And as I said, there's those three differences, right? Differences in their physiology, differences in their development, as well as differences in behavior. That the best described health effects for kids are respiratory effects, but that our knowledge about others is rapidly increasing. I left this bullet off, that cleaner indoor air spaces are the most important thing that you can do to keep yourself well during wildfire smoke events or your patients well. And that to remember that some kinds of masks and respirators can be used to decrease children's exposure as well as adults' exposure, but that there's really a need for a more coordinated regulatory structure to manage that entire process of respiratory protection for the public. And then I've got a bunch of references there.
Thank you, Stephanie. That was great, great information. I'm going to take a few questions from the audience. I think we have about 13 minutes or so. There are a couple of questions teed up, and not necessarily for one or the other, but maybe the first one, Stephanie, you can take first, and maybe John will have an opinion too. This is from Linda Newhouser. How can pediatricians or family physicians advise parents about finding good N95 masks for kids and fitting them correctly? So I think you talked a little bit about using a small adult N95 for kids. Are there other good masks that you would recommend? And how does a parent talk a kid through fitting the mask, and I would say wearing it?
Yeah, sure. No problem. So yes, trying a small adult N95 mask is a good way to go for your kids. I think one of the things that's unfortunate about our current regulatory structure is there's no standardization of sizing. So, people often think about this in terms of clothing, right? That if I go to one clothing store, whatever a size at one clothing store may be different than another clothing store. It's even worse among N95s. There's just no standardization at all. So the downside of that is that you may have to try multiple to figure out one that'll fit your kid's face well. That's frustrating, and that's tough, especially for folks with more limited means, right? Buying multiple respirators to try multiple is not always something that's super easy for folks to do. But looking for ones that are small, I personally, and this is just, N of one, so take it with a grain of salt, but I've had more luck for my child with the sort of duckbill style ones, as opposed to the more rigid. The reason for that, I think, is that the duckbill kind of fits to the face a little bit better because it, it adjusts and fits that shape. But again, that's, it just happens to fit my child better. So try with your own child. On the PACU webpage, we have information about how to do a leakage test. So when you put it on your child, to have them do deep breaths in and out and feel around the edges for leakage around the mask or respirator. And you should also see when they take a deep breath in that it should compress in a little bit. If they're exhaling out, it should push out a little bit. So those are all good things to do. You really want the one that fits them the best, fits them the most tightly. That does mean it's going to press on their face, right? And so that's challenging. Some kids really dislike that. Certainly kids with sensory issues, that can be really problematic. What you want to do is you want to go with the best mask that your child will wear, right? And so, as I said, you want it to be as good as possible at filtering and as good as possible at fit, right? So you do as much as you can do with your child on both of those two things. I have managed to get my 8-year-old daughter to wear an N95 for most of the school year this year. She's used to wearing them a lot at this point, but she has the advantage or disadvantage, as you like to think of it, of having a mom that's really knowledgeable about this, right? So that your mileage may vary, and certainly, as I said, you just do the best that you can with whatever you can do for your child. One thing that I often get asked specifically about, and this may have been something you were hinting at, Susan, so I'll just say it really quickly. I often get asked, well, aren't KN95s the same as N95s? They make children's KN95s, aren't those the same? They're not. And the reason that they're not is that KN95s, the material has to be really good, as it does for N95s and as it is for surgical and medical masks. But there really aren't regulations on fit for KN95s. And that's why, many of you will know that if you've worn KN95s, they may have ear loops. And you're like, well, these are much more comfortable. They don't push on my face. And that's true. They don't, right? And the problem there is that they're not sealing as well. And so, again, if you're trying to do the best thing you can get your child to wear, the material there filters well. So that's certainly better than a cloth mask. But if you can get your child to wear one that is more tightly fitting, like a small adult N95 that you can find that'll fit your child well, which takes some trial and error, that's a better option.
Great.
I would just add one thing, another type of mask that's people sometimes use are KF94. Those are from South Korea. They're better standardized in their manufacture than KN95s. There's been some pretty funky KN95s. Many KN95s are made of the same material that an N95 is made of, but there have been some sort of not so good ones as well. The KF94s are generally made well, but there's the same issue. The ones that fit around the ears are more comfortable, but they may not fit as well.
Yeah, and I'll just add to John's point there about some of them being funky, that there's also been studies at various points during the COVID pandemic that some of these devices coming in from internationally are actually counterfeit, that there's a really high proportion at various times that have been counterfeit.
That's especially true with the the KN95s, as opposed to the KF94s, which are generally pretty well regulated by the South Korean government.
And there was a publication during COVID, of course, not related to wildfire smoke, but just related to masks for COVID, that actually listed the companies that, were providing sort of good standard mask versus others.
It's a little bit out of date now, though. That's the problem.
Yeah. Another question from Laura Sullivan. Thanks for the information on fire.airnow.gov and on Purple Air for the purposes of checking day-to-day air quality. Do you recommend a particular website or information source for checking historical air quality data for a particular geographic location?
Sure, I guess my question back to, you, Laura, and I'll give answers for a couple different scenarios, but would be, why are you wanting to know, right? So if you're trying to look for historical information for the purposes of doing research, AirNow actually does publish those data. You can get to them through the EPA's page, and you can pull down spreadsheets of that information. If instead you're wanting to just sort of, I live in this geographic area, I want a sense of what my air quality is like, there are a couple places I would point you to. One is, your local air quality management district. Certainly in California, many of those have nice reports on their pages of, what the air quality has been like in the last few years. So John and I do a bunch of research work down in Fresno, and I know I was reading their reports recently for some stuff I was writing, and they have nice sort of glossy couple page reports sharing information about, where the area has been over the last few years in terms of meeting standards and what the main sources of air pollution are and all of those. The other place that's really useful is the American Lung Association. Every year, I think it's every year, right, John, does a state of the air report where they, list the metro areas with the highest air pollution, both the highest particle pollution, highest ozone pollution, and give information on pollution for your area. So if it's, if you're wanting sort of an overall overview to be able to talk to your patients about what air quality is like in your area, that would be a great place to turn.
Thank you. Stephanie, you might be able to answer this one too. When you're working with parents, talking to them about the types of masks and protections for their children, do you also talk with them about doing any kind of measures to assess their children, like heart rate or breathing rate or anything like that?
I haven't been saying that to parents. What I do say is that, you wouldn't ever want to use a mask or respirator with a child that's unable to tell you if they're uncomfortable, if they're having problems. So that includes infants, that includes children with profound developmental delays, adults, of course, with profound developmental delays as well, because you want to be able to have that as sort of your backstop right now, right? We have some information to suggest it's safe, but certainly if someone's feeling really uncomfortable, that's a great reason to take it off and make sure that they're in for a cleaner air environment.
Thank you. And Dr. Balmer, do you want to ask your question that's in the chat?
Hang on. Can you hear me now? So Stephanie, thank you very much for that excellent presentation, and both speakers actually. I assume that the mask is protective almost only for the particulate, the 2.5 to 10. On days that you have, let's say, LA smog with NO2 and ozone, and you have to be outside, is there any external outside device that would be appropriate or recommended for people that have to be outside in that atmosphere?
You want me to take that, Steph? Yeah, I just put something in the chat. Unfortunately, there's no easy to wear mask like we have for PM 2.5. I mean, they're called elastomeric respirators. You could actually, these are gas masks in the, public jargon, where you can put a charcoal filter cartridges in the mask. That'll protect you from ozone and NO2, but very few adults, let alone kids, want to walk around with an elastomeric mask. I don't think they're not even approved for kids. So bottom line, when there's a smog alert in LA or the Bay Area or wherever you are, you should stay inside as much as possible. And definitely you should try not to exercise outside, which increases your effective dose. That study I mentioned with regard to ozone and association with incident asthma in kids, it was for kids. The risk was for kids that played 3 outdoor sports, basically all year round, were, athletes. My son was such a person. Fortunately, he lives up here and we didn't get that much ozone exposure, but somebody who plays soccer and baseball and some other outdoor sport all year round, they're going to have increased risk of health effects from ozone. And that's why some schools in high ozone areas don't let kids go out for recess or play sports when there's a smog alert.
And I'll just add to what John said that, in addition to folks not wanting to wear a big, gas mask, as people call it in common parlance, there's not really enough information for the public to make a decision at any given point about, do I need to more protect from ozone and particles? And, we don't have that kind of information available to the public. There's not good labeling of which kinds of filters to use. So that's really not a good option for the public, even if someone wanted to at this point. We just don't have the framework set up for people to do that.
And actually, they're made for occupational exposures, so you're really supposed to be fit tested. So even though they look very impressive, if they don't fit the face properly, you won't get any protection anyway.
Okay.
And that applies for facial hair too. So people who have facial hair, it's much harder to fit them for N95. So nothing against John's beautiful beard there. So.
But actually, I don't know if Stephanie mentioned this. I don't think I heard it. Even a guy with facial hair like me, if I'm wearing an N95, I get a pretty decent protection. It's not going to be 95%. But it probably is around 80%. That's actually been looked at. And it all depends on how well trimmed your beard is. I need to trim mine, but
it's all a question of fit again, right? You want it up close to the face. I think my favorite story is that I one time was getting off BART during a wildfire smoke event and saw someone with a, big Bay Area style bushy beard with an N95 perched delicately on top that I could see into. I don't think that person was getting any benefit from that N95, right? But if John's wearing one that's very tight, he's going to have much better effect.
Yeah. And he can wear a PAPR or something when he's in the critical care area. I know we're at the top of the hour. Hattie, I don't know if you have any special comments, but I want to thank both of our speakers. It's great. Lots of variety. Thank you for also emphasizing the way we communicate with people, children and other high-risk individuals about staying inside and wearing masks. And hopefully we'll have some new materials to send out to people. I will send out a little survey link and ask people to give us feedback on the meeting, not on my terrible audio video at the beginning, but generally on the content. And that'll give you an opportunity. If you do want to receive materials, you can let us know at that time. And Hattie?
This question that I have is directed more toward John, since he deals with adults, and that is, for high risk heart, cardiovascular, stroke patients, what do you recommend? Do you recommend that their clinical teams have them have home HEPA filtration systems? I don't think that's part of the standard prescription, but should it be? You're muted. I'm sorry.
So that's a great question. And people are thinking about recommending portable HEPA filters for such patients. I certainly would, but there might be even official recommendations coming down the line. I know the American Thoracic Society has been considering whether they should be recommended, and some government agencies have considered whether there should be subsidies for low-income folks in wildfire-prone areas, for example. But without question, patients at increased risk, those with pre-existing heart and lung disease, diabetes, should try to reduce their exposure as much as possible, which usually means staying indoors and having a clean airspace like Stephanie described.
And preparing at the start of wildfire season, right? It's really hard to, when the smoke event is happening, get a hold of a portable air filtration device, get a hold of a replacement filter, get a hold of N95. So really, thinking about this as something that we do preventatively with these patients before, I'll put in air quotes, wildfire season, because wildfire season's getting longer and longer, certainly in California.
Yeah, and the other thing is have medication and clinical symptom management plan.
That's great. All right. Thank you very much. This just gives you a reminder that we have another session coming up on June 28th on innovative technologies to accelerate stroke detection and hospital arrival and hidden risk factors for early stroke and CVD. And again, really thank you to Dr. Balmes and Dr. Holm for educating us today. And we will see you on the flip-flop on June 28th. Hattie, anything else?
I just want to commend this wonderful scientific session by Dr. Balmes, Dr. Holm, Dr. Ivey. It's very moving what we're learning over time, and I could have enough questions to last for the next hour, but I won't torture everyone with that. I think maybe we should have a separate section on diabetes and pollutants and what that connection might be. How does that possibly work? What is the mechanism there? The other big question for another day is, if people have had high exposures in childhood with good air over time, does it reverse itself, the risk factors? So with that, I'll just say thank you so
Thank
much.
you.
And
Thanks so
we hope
much.
to have you back
Appreciate it.
with us again another time, and keep up the fantastic work. Thanks, everybody. And
right.
we'll see many
Thank
of you
you.
back here on Tuesday, June 28th from 4 to 6 p.m.
All right.
Bye now.
Thanks so much.